Hello and welcome students. In today's lecture, we are going to discuss about non-linear pharmacokinetics. So let us try to understand what is non-linear pharmacokinetics. So with some drugs, increased doses or chronic medication can cause deviation from the linear pharmacokinetic profile previously observed with single low dose of the same drug. So the specific reason for the occurrence of non-linear pharmacokinetic is that we are increasing the overall dose or we are going for the chronic medication in certain cases. Now this non-linear pharmacokinetic behavior is also termed dose-dependent pharmacokinetics. So earlier at low concentration we were able to observe the linear pharmacokinetic, but just because we are increasing the dose and we are increasing the amount of drug, now we are seeing the non-linear pharmacokinetic, which is also known as the dose-dependent pharmacokinetic. Now, many of these processes of drug absorption, distribution, biotransformation, and excretion involve enzyme or carrier mediated systems. Now, for some drugs given at therapeutic levels, one of these specialized processes may become saturated, and various causes of non-linear pharmacokinetic behavior are theoretically possible. So one such reason would be the saturation of various transportation system, and that lead to the non-linear pharmacokinetic profile of any individual drug. Now, besides saturation of plasma protein binding or carrier mediated systems, drugs may demonstrate non-linear pharmacokinetics due to the pathologic alteration in drug absorption, distribution, and elimination. So, there are certain situations in which the disease state is bringing some pathological changes inside the human body, and because of these pathological changes we are seeing alteration in the absorption, distribution, and elimination of drug. Now, for example, the aminoglycosides may cause renal nephrotoxicity, thereby altering renal drug excretion. So a specific example has been given that a disease state where the kidneys are affected will bring the changes in the excretion of certain drugs, and aminoglycosides may cause renal nephrotoxicity and thereby altering the renal drug excretion. In addition, gallstone obstruction of the bile duct will alter biliary drug excretion. So one more condition has been given that because of the obstruction of the bile duct, it will alter the biliary drug excretion. Now, in most cases, the main pharmacokinetic outcome is a change in the apparent elimination rate constant. A number of drugs demonstrate saturation or capacity limited metabolism in human. So after certain level of metabolism there is a saturation. So the extra quantity of drug which we are supplying may not undergo metabolism because the saturation has been attained. Now the example of these saturable metabolic processes include glycine conjugation of salicylate, the sulfate conjugation of salicylamide, acetylation of para-aminobenzoic acid, and the elimination of phenytoin. So these are some classic examples in which the drug's metabolism reaches to the saturation, and after that linear pharmacokinetic is not possible, and thus we are observing the non-linear pharmacokinetics. Now, the drugs that demonstrate saturation kinetics usually show the following characteristics. The elimination of the drug does not follow simple first order kinetics, that is, elimination kinetics are non-linear. So, this is the first thing you will observe in any particular drug, which is not supposed to follow the saturation kinetic. The elimination half-life changes as dose is increased. Usually, the elimination half-life increases with increased dose due to saturation of an enzyme system. So here the situation is arising because of the saturation of enzyme system, and just because the saturation of enzyme system is attained, extra quantity of drug will not undergo any kind of enzymatic degradation or metabolism. However, the elimination half-life might decrease due to self-induction of liver biotransformation enzymes, as is observed for carbamazepine. So there are some instances in which the reverse is also possible, that the elimination half-life decreases because of the active role played by the liver and the metabolism which takes place inside the liver. Now the area under the curve, that is AUC, is not proportional to the amount of bioavailable drug. The saturation of capacity limited processes may be affected by other drugs that require the same enzyme or carrier mediated system. For example, in competition effect. So two or more drugs will compete with the same metabolic pathway which is led by a specific enzymes, and because of that we'll see the non-linear pharmacokinetic. The composition and or the ratio of the metabolites of a drug may be affected by a change in the dose. Now, because these drugs have a changing apparent elimination constant with larger doses, prediction of drug concentration in the blood based on single small dose is difficult. So the situation of non-linear pharmacokinetic leads to the difficulty in mapping or difficulty in estimating the concentration of drug into blood with single small dose. Now the drug concentration in the blood can increase rapidly once an elimination process is saturated. In general, metabolism and active tubular secretion of drug by the kidney are the processes most usually saturated. Now this particular graphic would help you to understand that how the plasma level time curve for a drug that exhibit a saturable elimination process. Now curve A and B represents high and the low doses of drug respectively given in a single IV bolus. The terminal slopes of curve A and B are the same. Curve C represents the normal first order elimination of a different drug. Now when a large dose is given, a curve is obtained with an initial slow elimination phase followed by a much more rapid elimination at lower blood concentration, that is the curve A. Now with a small dose of the drug, the apparent first order kinetic is observed. Now because no saturation kinetics occurs, that is in curve B. Now, if the pharmacokinetic data were estimated only for the blood levels described by curve B, then a twofold increase in the dose would give the blood profile presented in curve C, which considerably underestimates the drug concentration as well as the duration of action. Now, in order to determine whether a drug is following dose-dependent kinetics, the drug is given at various dosage levels and plasma level time curve is obtained for each dose. The curves should exhibit parallel slopes if the drug follows dose-independent kinetics. Alternatively, a plot of the areas under the plasma level time curve at various doses should be linear. So with the help of these graphs, you can understand the dose dependent or the non-linear pharmacokinetic and the linear pharmacokinetic. Now in this particular figure, the area under the plasma level time curve versus dose for a drug that exhibit saturable elimination process. Now curve A represents dose dependent or saturable elimination kinetics, whereas the curve C represents dose independent kinetics. So that was all about the basic idea behind the non-linear pharmacokinetics of drug. Please go through this video and let me know if you have any query or question. Thank you very much for watching. Have a good day.